Here are the objectives of today's talk. We will introduce the new nomenclature. We will review the current epidemiology of liver disease. We will identify patients at risk for progressive or advanced liver disease. We will discuss the role of non-invasive testing and screening for advanced fibrosis. And finally, we will present a new in-house clinical decision support tool for triaging patients to hepatology. Let us begin. So as of June 24th, 2023, NAFLD and NAS are no more. All hail MASLD, which stands for Metabolic Dysfunction Associated Steatotic Liver Disease. So why, after almost 40 years of using the term NAFLD, did we decide to replace it? The truth is that it was never ideal to begin with. So we wanted this disease to be defined by what it is and not by what it isn't. And we wanted that definition to allow us to distinguish between all its possible etiologies, and in the process we wanted to avoid language that patients may find stigmatizing or pejorative. So after a lengthy process of about a year and a half, we established terminology agreed upon by all major hepatology societies. We are now using the blanket term steatotic liver disease, and the presence of at least one metabolic risk factor, essentially identical to the ATP3 criteria, steers us towards this direction of MASLD. Whether we give the patient that diagnosis relies on the presence or absence of other steatogenic processes. Specifically, if a patient consumes more than a moderate amount of alcohol as defined by the NIAAA, so more than one standard drink per day in a female patient and more than 2 standard drinks a day in a male patient, we now veer into this new category of MET ALD, where many patients we see in clinical practice may fall into. And the predominant driver of steatosis is determined by the exact amount of alcohol consumed on a daily or weekly basis. Now, if no metabolic risk factors are present and no significant amount of alcohol is consumed, then other causes of secondary steatosis need to be sought. So these can be drugs. A classic example is methotrexate. Diseases like celiac, Wilson's, hepatitis C, mitochondriopathies that our pediatric colleagues may see in their patients, and finally, we have a cryptogenic or idiopathic diagnosis where no discernible factor can be identified. Now, this slide shows a hallmark of the MASLD spectrum. This is steatohepatitis, the progressive or more aggressive form of MASLD, and the one that is associated with high risk for developing advanced liver disease. This is strictly speaking a histologic diagnosis. So the non-invasive detection of steatohepatitis is somewhat of a holy grail in the hepatology world. And we will be touching upon a surrogate marker later on. For now, I will just introduce its new name. This, of course, stands for metabolic dysfunction associated steatohepatitis and not Mobile Army Surgical Hospital. Moving on to the epidemiology of MASLD. A large and oft-cited epidemiologic study estimates that the prevalence of MASLD in North America is about 25%, which means that, assuming a US population of about 320 million, we have about 83 million patients with MASLD. And if we then project the inherent epidemiology of the disease onto that population, in essence where patients fall across the MASLD spectrum, we estimate about 16 million with MAS and over 3 million with MAS cirrhosis. And from here, the only way is up. So statistical models estimate that there will be over 100 million with MASLD by 2030, and among them 8 million with advanced liver disease, with a concordant rise in the incidence of hepatic decompensation, hepatocellular carcinoma, and liver-related death. And actually, this is already happening. So the future is now. So we already know the rising trends of deaths due to MASLD-related cirrhosis and MASLD-related HCC. MASLD and alcohol-associated liver disease are vying for the top spot of the most common indication for liver transplant in the United States. MASLD is winning when it comes to women and patients transplanted for HCC. But if North America is heading towards a 30% prevalence, Latin America has already been there for years now. And 1 in 3 Hispanic patients have MASLD. So Hispanic ethnicity has been shown to be a risk factor for underlying MAS. Among MAS patients, Latinos are significantly younger, and they tend to have the most aggressive histology. And there seems to be a genetic component to the predisposition of Hispanic patients towards developing hepatic steatosis. Several genes and their polymorphisms have been identified, and more are expected to be found, the foremost among which seems to be the PNPLA3 or adiponutrin gene. So certain polymorphisms in this transcription factor gene seem to be associated with increased lipogenesis and decreased lipolysis in the liver. So it shouldn't come as a surprise that across BMIs and among non-diabetic patients, there is significantly higher prevalence of steatosis in Latinos than in white or black patients. In those with diabetes, however, all bets are off. Studies investigating the prevalence of steatosis in diabetic patients show that it is present in the majority of them. And what is more alarming, however, is the number of patients with MAS and advanced liver disease. It also appears that hepatic fibrosis progresses significantly faster in diabetic versus non-diabetic patients. So where do we stand as primary care physicians when faced with this tidal wave of MASLD? We are, after all, the first line of defense. A study from Johns Hopkins presented at the last liver meeting showed that the considerable number of patients carrying the diagnosis of MASLD and MAS seen in their primary care offices had insufficiently evaluated liver disease, and referral to specialty care was low even in those diagnosed with advanced liver disease. So this reminds me of an internal audit that we did at EBNHC a couple of years ago. So we looked past the patients with metabolic syndrome or even a diagnosis of steatotic liver disease and instead focused on those that were given this diagnosis of non-specific hepatitis. And among these patients, we tried to find those with true chronic liver disease, whether that disease was listed among their chronic conditions, whether the most elementary workup had been performed, whether steatosis was seen on any imaging they may have had, if they had been staged with any modality, and finally, if they had been referred to hepatology for evaluation. So we identified 756 patients with chronic liver disease, predominantly Hispanic. Over 1/4 of them did not have chronic liver disease listed among their medical problems. So in 1 in 5, viral hepatitis was not excluded. Less than half had an abdominal ultrasound performed at EBNHC. And of those who had any imaging study that could potentially visualize the liver, either internal or external, 45% had steatosis. A very small number, a very small proportion had been staged or referred for specialty evaluation. And of note, patients who had chronic liver disease documented in their problem list were more likely to have adequate workup than those who did not. Finally, Healthcare disparities are also present when it comes to the assessment of chronic liver disease. Data shown here from the University of Alabama in a predominantly African American population show that minority patients were significantly less likely to receive basic or specialty evaluation of their liver disease. So MASLD is an epidemic and a public health crisis in the making. An alarming proportion of diabetics have underlying advanced liver disease. Hispanics are prone to developing MASH at a younger age. Primary care has a very important role to play in identifying those patients at high risk for advanced liver disease and triaging them to specialty care. And unfortunately, it seems that ethnic minorities may receive inadequate liver care, certainly disproportionate to their elevated risk. Moving on. Why is it important to establish as reliably as possible the degree of underlying hepatic fibrosis, if any? That is because it has been shown to be the most important determinant of mortality in these patients, with survival decreasing exponentially with escalating fibrosis stages. And why avoid invading? Despite still being considered the gold standard for staging liver disease, a liver biopsy is far from perfect. So accuracy is dependent on both the sample obtained, its size, and its origin in the liver parenchyma, and its assessment by the pathologist. There is also the risk of complications, although they are very rare, and needless to say, it wouldn't be feasible to perform a liver biopsy on all patients with MASLD. We have therefore tried to identify serum components either directly implicated in this cascade of hepatic fibrogenesis or that imply a significant risk due to the changes they undergo as a result of underlying advanced liver disease. And in our 20-year quest to develop non-invasive methods to assess for the presence of hepatic fibrosis, a slew of non-proprietary and proprietary markers have been developed. We will focus on the two most extensively studied, the FIB4 and NFS. So FIB4 was in fact not developed for MASLD, but rather to assess the risk of underlying cirrhosis in patients with hepatitis C and HIV co-infection. NAFLD fibrosis score, on the other hand, as the name implies, was developed specifically for MASLD. Both are very cheap to obtain and easily calculated online or through EPIC. How do they perform in MASLD? So one answer is shown here, provided by the investigators of the NAS Clinical Research Network. So this was a study that involved over 1,400 biopsy-proven patients with MASLD, 83% Caucasian, and less than 40% diabetic. Both markers, but especially FIB4, performed well. So an area of under the curve of 0.86 means that the test correctly classified patients 86% of the time. And a cutoff of about 1.3 excluded cirrhosis with 98% confidence. These markers have also been found to be of prognostic and not just of diagnostic value. So rising FIB4 values over time appear to be highly correlating with an adverse liver-related event, in essence hepatic decompensation, hepatocellular carcinoma, death from liver disease, or liver transplant. And their prognostic value is not limited to liver-related events. So from enhanced data, it seems that high FIB4 and NAFLD fibrosis score are independently associated with a higher all-cause mortality, and the high FIB4 is associated with higher cardiovascular mortality. Are they cost-effective? The answer seems to be yes. A 2016 study showed that calculating NAFLD fibrosis score at the PCP office and triaging to specialty care based on results was the most cost-effective strategy, followed by the combination of NAFLD fibrosis score and Fibroscan. A more recent study from Canada also concluded that calculating FIB4 and then referring patients with a score over 1.3 for elastography were the most cost-effective strategies. So based, I'm sure, at least on some of the above, the ACG, the American College of Gastroenterology, first published a guidance document in 2021 recommending a FIB4 first approach to staging patients with MASLD or screen those at risk for it. So for those with a FIB4 less than 1.3, continued monitoring and standard of care were recommended. And then for those with an indeterminate FIB4, Fibroscan was recommended as the second step. A liver stiffness less than 8 kilopascal brings patients back to primary care, while values above 8 and especially above 12 warrant hepatology evaluation and more aggressive management of metabolic disease, preferably with agents with direct or indirect hepatic benefits such as GLP-1s and pioglitazone. Guidance statements published in 2022 by the American Association of Clinical Endocrinology and in 2023 this year by the ASLD support an almost identical algorithm. And an abstract presented at the most recent ASLD meeting confirms confirms the cost effectiveness of such a strategy, as well as that any screening really is more cost effective than no screening. Now, this is our in-house guidance, somewhat more convoluted and intentionally divergent. Why is that? Why are we not following the guidance? So let's explain. What if instead of 1,400 patients, we had a sample of 14,000? And what if instead of just predominantly white North American patients, we expanded this sample to include patients across continents, South America, Europe, Asia, and Australia? Then you would have the largest meta-analysis of FIB4 and NAFLD fibrosis score in literature. And looking at these data, one notices two important findings. Number one, with a much larger sample of patients, the performance of FIB4 in detecting advanced liver disease is decidedly worse. Number two, while FIB4 still performs well in European, i.e. in white patients, it does not seem to be performing as well in other ethnicities. And while the performance of FIB4 does not appear to vary significantly across ranges of excess weight, data from another large meta-analysis shows that excess weight actually does affect the performance of FIB4 as it does Fibroscans, actually. Expanding on this idea of ethnicity as a factor in the performance of FIB4 and NAFLD fibrosis score, here is a relatively small study of Hispanic patients with biopsy-proven MASLD. So these were 99 patients. And as we can see, the negative predictive value of FIB4 in excluding advanced fibrosis in these patients was far from 98%. Which is, if you think about it, very, very logical considering what we know about the epidemiology of the disease in these patients. And what about diabetic patients? Here you will find the diabetic subgroup of a meta-analysis of 37 studies, the original intent of which was actually to assess the performance of Fibroscan, and they included over 1,700 diabetic patients with biopsy-proven MASLD. Again, a FIB4 of 1.3 did not have a 98% negative predictive value for advanced liver disease. A cutoff below 1, the NAFLD fibrosis score, and above all, Fibroscan performed better. So the authors of this study advocated for elastography-based triage of diabetic patients rather than a FIB4-based approach. What about MASH? What about patients who do not yet have advanced liver disease, but they are at high risk of developing it, and as such would benefit from closer monitoring and intensive and liver-specific treatment? So in the initial phase of the Maestro-NASH trial, which is an ongoing phase 3 clinical trial evaluating the safety and efficacy of resmetirom, a thyroid receptor beta agonist, in the treatment of MASH, over 2,000 patients were screened with liver biopsies. Over half of patients with MASH with significant fibrosis had a FIB4 less than 1.3, making its overall performance in this setting somewhat better than a coin toss. The authors also noted that MASH patients with a FIB4 over 1.3 were significantly older by 10 years, suggesting that the lower threshold of less than 1.1 may be more useful. Which is a good segue to talk about how age affects the reliability of FIB4. It is, after all, a part of the equation. So, throughout the non-invasive testing literature, the mean or median ages of the population studied fall consistently within the range of middle age. So, the authors of this study explored the performance of FIB4 and NAFLD fibrosis score in 634 biopsy-proven MASLD patients, where about 74 of them were younger than 35 and 76 were older than 65. So in the younger population, the performance of FIB4 was atrocious. Admittedly, there were only 8 among them with advanced liver disease, but FIB4 detected none of them. And when it came to older patients, FIB4 performed reasonably well overall, but the specificity and the positive predictive value of the 1.3 cutoff were low enough such that it would triage to further evaluation and a necessary number of patients. So the authors found that a cutoff of 2 had an excellent negative predictive value, and they proposed that cutoff to be used in this age group. Finally, neither FIB4, NAFLD fibrosis score, or any other non-invasive test has been studied, much less validated, in the presence of 2 coexisting liver diseases. So in all the studies that we have shown, patients either did not drink alcohol at all or drank an insignificant amount, so FIB4 has not been studied in MET-ALD. And to offer proof that others in the field share similar concerns, here is a late-breaking abstract presented at the last liver meeting by none other than the oncoming president of the ASLD, Dr. Ray Kim from Stanford. So this was a study where they used data from NHANES, aiming to compare their in-house triaging tool called SAFE, stands for Steatosis Associated Fibrosis Estimator, to FIB4. So discussing SAFE is not within the scope of this presentation, so anyone interested can visit the website listed. Instead, I would like to focus on this. So among about 2,700 patients meeting criteria for MASLD, in whom both FIB4 and Fibroscan data were available, the majority of patients with an elevated liver stiffness implying either significant or advanced liver disease, they had a low FIB4 score. And as someone in the audience correctly pointed out, an elevated liver stiffness does not fibrosis make. However, the point made here is that the same patients who, based on their liver stiffness, would warrant specialty evaluation according to the guideline would be deemed to be safely triaged to primary care based on their FIB4 per the same guideline. So the conclusions of this chapter. FIB4 and athlete fibrosis score are the most extensively studied serum-based markers for MASLD. They have prognostic in addition to diagnostic value. They provide, a cost-effective way of triaging patients to specialty care. They have good exclusionary capacity in middle-aged, white, non-obese, non-diabetic patients who do not drink or consume insignificant amount of alcohol. They may underestimate or overestimate the presence or severity of underlying liver disease in all others. And in high-risk patients, additional testing should be considered for further exclusion of advanced fibrosis. So the idea behind this convoluted little guide is to act as a safety net, to bring to hepatology patients whose risk for advanced or progressive liver disease may not be accurately reflected by their FIB4 score. So this was the best we could do until now. We'll begin by introducing the term elastography, which is measuring an organ's stiffness. So this is a surrogate marker for fibrosis and is estimated by calculating the velocity of a shear wave traveling through tissue. And out of several elastography modalities, vibration-controlled transient elastography, also known as Fibroscan, introduced in the early aughts, is the most widely used and extensively studied. Let's see how Fibroscan works. This video will do a much better job explaining that than I ever could.
Fibroscan is powered by vibration-controlled transient elastography, or VCTE. Here is how this unique method for assessing liver stiffness works. A 50 Hz shear wave is mechanically induced from the tip of the Fibroscan probe. To the patient, this feels like a slight flick or tap on the skin. The mechanical shear wave travels through the liver tissue. The shear wave's speed is measured by ultrasound pulses which reflect off the wave as it passes through the 3 cubic centimeter exam cylinder. The speed of the shear wave is used to calculate liver stiffness, reported in kilopascals. Here, the shear wave moves slowly through a healthy liver. In a cirrhotic liver, the shear wave moves very rapidly. In addition to liver stiffness, Fibroscan simultaneously calculates ultrasound attenuation rate within the explored 3 cubic centimeter volume. This assessment, known as Controlled Attenuation Parameter, or CAP, is associated with the extent of fat present in the liver tissue. Ultrasound pulses are generated from the Fibroscan probe. As fat builds in the liver, the rate of ultrasound signal absorption increases, resulting in a higher CAP value reported in decibels per meter. A low attenuation rate is associated with lower levels of fat. A higher attenuation rate is associated with a higher level of fat in the liver tissue.
So this is non-invasive and well-tolerated point-of-care testing that quickly produces results and can be repeated as clinically indicated. It does not visualize the liver parenchyma. Fibroscan is not imaging. Its cost is higher than a FIB4, but much lower than other modalities, and the cost has steadily decreased since it was first made available. Fibroscan is more sensitive than an abdominal ultrasound in detecting steatosis, so an ultrasound generally requires over 20% of parenchymal involvement, whereas a Fibroscan can detect it even at 10%. Fibroscan is not as good, however, at quantifying steatosis, so it cannot discriminate well between moderate to severe steatosis. The inverse applies to fibrosis. So while Fibroscan is not exquisitely sensitive in detecting mild to moderate hepatic fibrosis, it performs much better when it comes to detecting underlying advanced liver disease. In a study of 120 biopsy-proven MASLD patients, a liver stiffness less than 8 essentially excluded the presence of advanced fibrosis, and the overall performance of Fibroscan was excellent and significantly superior to NAFLD fibrosis score. The superiority of Fibroscan over FIB4 and NFS is further confirmed by a meta-analysis of 37 studies involving over 5,000 patients with biopsy-proven disease. Still, a significant proportion of patients fell into an indeterminate range between the optimal cutoffs, and the authors showed that combining Fibroscan with FIB4 or NAFLD fibrosis score drastically reduced this proportion of patients. Is Fibroscan cost-effective as a first-line test? We do not have a wealth of data on this. It can be, as demonstrated by the study from Singapore, in which it was used to screen for advanced fibrosis, diabetic patients between ages 50 to 70, and was compared to FIB4 alone, a combination of Fibroscan and FIB4 or sequential screening. So Fibroscan seemed to be the most cost-effective option, with FIB4 alone being second best. Now, what else can we use the Fibroscan for? To quote the internet, the answer may surprise you. In recent years, several elastography-based scores have been developed to detect the presence of MAS with significant fibrosis or stage 2 fibrosis. The Fibroscan AST score or FAST score is one of them and seems to be performing well in ruling this out, especially among non-white patients. Also, long gone are the days when patients were referred for an endoscopy to screen for varices upon diagnosis of cirrhosis. We now follow the Baveno criteria, and we use a combination of liver stiffness and platelet count to either exclude or rule in clinically significant portal hypertension. Now, what are the limitations of Fibroscan? So here you will see the factors associated with either test failure or obtaining unreliable results. And you will notice that a high BMI followed by operator experience are by far the most important ones. So this is very much an operator dependent exam with a very high failure rate in patients with a BMI over 40. So these patients should not be referred for a Fibroscan. Instead, they should undergo MR elastography, which is the optimal non-invasive test to stage them. This is largely due to what we call the skin-to-capsule distance. So with higher levels of obesity, the deeper the probe needs to induce and follow the shear wave. Now, the introduction of the XL probe has significantly helped to overcome this limitation without really sacrificing diagnostic performance. Sometimes though, even if a patient has a relatively low BMI, their anatomy may just not be conducive to the exam. For example, someone who has a very narrow intercostal space. Now, for the confounding factors that may falsely elevate liver stiffness, first we have a postprandial state which increases blood flow to the liver, so patients should be instructed to fast for 3 hours before the test. A high necroinflammatory state in the liver can significantly raise liver stiffness, so patients with moderate hepatitis, as defined by an ALT over 200 or 300, are unlikely to get an accurate estimate of underlying fibrosis, so these patients should be biopsied. Same applies to biliary obstruction, so these patients should not be sent for a Fibroscan until well after the obstruction has resolved. And the severity of steatosis has also been found to affect liver stiffness, albeit to a lesser degree. Any condition that increases intrahepatic pressures, so for example, heart failure or restrictive cardiomyopathy, or hepatic vein thrombosis, what we call bad Chiari syndrome. Patients with volume overload, again, of course, of either cardiac or renal origin, also are not very good candidates for elastography. Now, pregnancy and ascites both used to be contraindications to a Fibroscan. Neither of them are any longer. In terms of pregnancy, we have data showing that Fibroscan is perfectly safe and may have prognostic value when it comes to predicting preeclampsia. Of course, because liver stiffness seems to be reversibly rising in pregnancy, it may not be an ideal time to use Fibroscan to stage these patients. In terms of ascites, quite honestly, performing Fibroscan would both be technically difficult, if not impossible, and would add little to no clinical information. So Fibroscan is a safe, non-invasive point-of-care test. It allows the detection of hepatic steatosis with greater sensitivity than an abdominal ultrasound, the exclusion of advanced liver disease with greater confidence than serum-based markers, the detection of patients at risk for liver disease progression or hepatic decompensation. An abnormal Fibroscan result always needs to be confirmed with further testing, either non-invasive or invasive. Patients should never be diagnosed with advanced liver disease on the basis of Fibroscan alone. Confounding factors should be taken into account when ordering the test or performing it. So elastography is less helpful in those with moderate to severe liver injury, so a liver biopsy is the most accurate modality to assess the degree of fibrosis in these patients. Where do we go from here? So shown here is the new MASLD decision support tool, which will replace the old one. So patients will be triaged to primary care or hepatology based on liver stiffness measurements and FAST scores. As a primary care physician myself, I'm well aware of our plight and just how many things we have to juggle on a given visit and within our time constraints. So my first pledge is to make this process as easy as possible. So here's an example of a statement that we can use to offer screening to patients that are candidates for it. If interested, then they usually are, an internal referral for a Fibroscan can be placed and then to be used by an MA or a secretary to book the appointment. All referrals fall into a work queue that I personally tend to, and then the contact center staff have also been shown how to schedule or reschedule a test if necessary. A pamphlet like this is going to be shared with all practices in a PDF format. It can be used as an appointment reminder and for patient education. And again, reminding everyone that all patients should fast for 3 hours and wear loose-fitting clothes. The results will be sent to the referring provider within minutes of completion of the test, and my second pledge is to give you a clear-cut impression and recommendations for the next steps. I will leave you with this website of a non-profit based in Philadelphia and founded by a liver transplant recipient. Please encourage your patients to visit this website. It is very well informed and stresses the particular risk of MASLD and MAS in Hispanic patients. We have a poster up in adult medicine, we have pamphlets, and we will be very happy to share in other spaces. That's my time for today, and we can open the floor to questions.